Thanks everyone for joining us today for this very important topic. So today speaking, we have Dr. Stacie Collins, who's a second-year child and adolescent psychiatry fellow right here at UCSF. She received her bachelor's in psychology with a minor in biology from Howard University, and she attended medical school at UCLA, where she was a part of the Charles Drew University Medical Education Program, which is a program for individuals who are to work with underserved communities. Dr. Collins completed her adult residency in psychiatry at UCLA, Greater Los Angeles VA training programs. So thank you so much, Dr. Collins, and I'm going to turn it over to you.
All right, thanks Dr. Hack for that introduction, and thanks to all of you for being here. I know it's been an exciting morning with inauguration, and there are other things you could be paying attention to, but you're here with me, so I appreciate it. So let me just go ahead and share my screen so we can see my slides. Okay, so the plan for today is to talk about racial trauma, and I picked this topic for a couple of reasons. The first reason being that I personally have really appreciated the conversations that we as a department and as a university have been having over these last 6 months or so around race and racism and things that we can do to work towards more equitable treatment of everyone. So just given the opportunity to continue that conversation, I wanted to take it. And then the reason I wanted to talk about racial trauma in particular is because I do think it's a really pervasive issue that we might not all know a lot about, and that we may not be keeping sort of in the forefront of our minds. So I'm hoping to just bring a little awareness to the topic today. So goals for today, we want to understand what racial trauma is and how it manifests. We want to understand diagnostic implications of racial trauma, to become familiar with assessment tools and strategies for evaluation of racial trauma, to become familiar with interventions for addressing the effects of racism, and to learn ways of engaging in anti-racist healthcare delivery on both a clinical and systemic level. So just to get us started, I wanted to present a few cases. So case number 1. We have a 13-year-old Korean American female with a recent diagnosis of MDD and significant school avoidance who presents for CBT and med management. She recently moved to the Los Angeles area and started at a new predominantly white middle school. Patient had historically been considered to be social with good friends in the town she grew up in, but she had trouble making friends at her new school, which teachers attributed to her being shy. After several months in therapy, the patient revealed that she dreaded going to school because a group of students were calling her racial slurs and making verbal threats. Case 2, we have an African-American male in 3rd grade with ADHD who presents to clinic for med management. He had previously done quite well in school, but this year school performance was slipping and behavioral problems were increasing. Collateral information from his teacher revealed that she was intentionally keeping him in a lower level reading group to inspire the other African-American children to perform at his level. She also reported that the patient required frequent redirection around lies he told to other students about being on a swim team and a club ski team. It turns out the patient was in fact on both teams, but the teacher was under the impression that African-Americans were not good swimmers due to differences in buoyancy. And for our last case, we have a 16-year-old African-American female with OCD who presents for CBT. Her rituals included hand washing and frequent checking. And a little background on this patient, her father was incarcerated for charges related to marijuana possession and distribution. And her most recent flare-up in symptoms coincided with his contacting her after over a year of not speaking. So again, I wanted to start with these cases just to get us thinking and maybe thinking about our own cases. And I chose these 3 cases in particular because I think they do a nice job of illustrating different ways that racism and in turn racial trauma can be present in the lives of our patients and the lives of people of color in general. So in the first case, we were seeing an example of overt racism. So slurs and threats, things that can be very readily recognized as racist. The second case, we're seeing more like microaggression stereotyping. I don't know that this boy's teacher recognized that she was being racist. I think she probably thought that she had good reason for acting in the way that she did. But even without any malintent, this boy was still adversely affected. And in this last case, we're looking at more about racism on a systemic level. So I think we're all aware that people of color are disproportionately impacted by the criminal justice system, and Black and Latino men in particular are more likely to get harsher sentences compared to their white counterparts. And this case just sort of points out that it affects not just the person that's incarcerated, but the entire family system and the community as a whole. So with those cases in mind, and again, sort of to get us thinking about our own cases, I wanted to ask a quick question, and we'll do it in the form of a poll. How many of you have treated a patient where issues of race or racism were part of the clinical picture? And so Sam, if you could launch the poll, we'll give a few seconds for people to answer.
Sure, I think give me 1 second.
Okay.
Are you able to see the questions?
I can see them.
Okay, cool. Yeah, I do see we have about 50 responses so far. We'll give it maybe another 10 seconds and we'll close poll.
Sounds good.
Okay, cool.
Okay, this might be a good place to start. It looks like we have some good answers. So I guess I can end it and I'll share our results just so we can all see. Can everybody see those results? I can't see anybody, so I'm not sure if you can, but if you can see them, you will see that it looks like a lot of people are doing a good job of recognizing when issues of race and racism are entering into the clinical picture. And maybe some people are not able to think of specific examples right now, or maybe are not so sure. But I would argue that regardless of what your answer is, that it's probably coming up more than you're aware of, and maybe even more than your patient is aware of. So, again, today we'll just talk about ways that we can keep that awareness in our minds. Okay. Second question I have is, on a scale of 1 to 5, how comfortable or well-equipped do you feel addressing these issues?
Are you able to see the second question? Okay, cool.
Stacie, this is 5 being like most well-equipped and 1 being least?
Yes, thank you for clarifying that. I should have clarified that in the question. Okay, we'll give it just a couple more seconds. All right, let me share those results. So yeah, here we're seeing a pretty good range, a lot of answers across the board. And I would say that if you're not comfortable, really, I don't think it should come as a big surprise, because I don't think this is something that's covered in a lot of depth in our training traditionally. So just another reason I wanted to talk about this today. All right, so let's go forward with a definition. So racial trauma. This is the physical and psychological symptoms that people of color often experience after being exposed to stressful experiences of racism. And people of color can experience racial trauma in a number of different ways. It can come in the form of threats of harm and injury, from humiliating and shaming events, and also from witnessing racial discrimination towards other people of color. So it's actually something that can also be experienced vicariously. The other really important thing to note about racial trauma is that these are not experiences that exist in isolation. So if we are comparing racial trauma to other forms of trauma, in other forms, in many cases, not all cases, but many cases, we may see that it's stemming from a single event or a series of discrete events that are related. But when we're talking about racial trauma, we're really talking about repeated and ongoing experiences that are ultimately connected. So each new experience of racism that a person has is a reminder of previous experiences. It's a reminder of racism that other people in their race have experienced over time. So it's really something that is compounding. And just some of the things we mentioned, things like experiencing microaggressions, being called a slur, watching people that look like you being portrayed or treated a certain way in the media. All of these experiences can happen on an ongoing, on a continuous basis, and they can all add up to equal racial trauma. Another really important thing to note about racial trauma is that the trauma can begin before the individual has even had their own personal experiences of racism that they're aware of or can identify themselves. And that really segues us into the concept of intergenerational trauma. So this is the process of transmission of trauma from parent figures to their infants or children, resulting in the effects of trauma being experienced by the second generation without exposure to the original traumatic experience or event. So typically transmitted via genetic patterns or interactional pathways. And it's typically unintentional and without awareness of the contribution of the original traumatic event. Even with it being unintentional, it can unfortunately have significant impact on mental health. So when we're talking about intergenerational trauma, this is usually something that we see within individual families. These are adverse experiences, different forms of trauma that the effects can trickle down from the parents to the children, even if the children themselves have not had firsthand experience with the trauma itself. And if we zoom out even further, then we can see historical trauma. And historical trauma is a cumulative, multi-generational, collective experience of emotional and psychological injuries in community and descendants. The concept of historical trauma was first looked at in Holocaust survivors and their descendants. So over multiple generations, there was an increase in PTSD, vulnerability to stress, anxiety, depression. All these things were seen over the course of generations. Since those studies were done, studies in historical trauma have been done in a number of other marginalized groups. So certainly there's been a lot of studies done on Native American communities. So Native Americans, as a result of their experiences with colonization, murder, removal and banning of their cultural practices, we're now seeing high rates of depression, alcohol and other substance addiction, PTSD, and also really high rates of suicidality. And of course, it's also been studied in African-American populations, where we can go back to slavery and all the subsequent discriminatory public policy that followed, and see that today it continues to have an effect on generations later. So these are really far-reaching effects. Okay. Oops. Okay. This next slide, I just sort of summarized a newly developed concept where a case is being made that racism is both a risk factor for adverse childhood experiences and that racism is an adverse childhood experience in and of itself. And from there, the theory goes on to argue that racism contributes to post-ACE mental health vulnerability. So I'll just walk us through it really quickly. And I will say that this was originally made with African Americans in mind, but I do think that for any population of people of color who have experienced systemic racism or have this historical trauma, it would apply just as well. So starting here with historical trauma, which again is something that the child has no control over and may not even have awareness of, but still it gives rise and is followed by racism-informed social conditions and also biopsychological vulnerabilities. And then all three of these things together increase the likelihood that the child will have an adverse childhood experience. That's both the traditionally defined ACEs and racism as an ACE as well. So now we have these kids who have these ACEs, but the racism-informed social conditions and the biopsychological vulnerabilities are still there. They still exist. And they serve as barriers to these kids developing the coping skills and also getting adequate access to treatment that would help them to address these ACEs. And that results in poor mental health outcomes. So again, just a way of framing it where we see that this historical trauma is really far-reaching and can have effects over many generations. What I want to do now is just show a quick video just to get a different perspective. So I'm going to stop sharing this and I'm going to share the video. Okay.
I'm from Haiti and Nigeria. Like three things, like I'm Dominican, Puerto Rican, and Black. I'm biracial. I have an African American father and an Irish American mom. My name's Lamine. I'm Muslim. I'm Indian, British, Scottish, and American. My parents are from Venezuela, and I was sharing like one of the foods that we eat, and then I got made fun of. They were like, "What is that? Ew! Oh, ew! What is that?" And like I cried because I felt like, oh, there's something wrong where I'm from. Like maybe like it's bad. Like I'm different. I am an African American adopted girl, only child, and I live with my two dads. I remember when I was younger, I went with my family to a restaurant, and they made us pay in advance just in case we didn't pay afterwards, and that was kind of upsetting. You start to notice that people are different, and you have comments. They might be racist or they might not be, but by the time you get older, you know that it is racist and you should stop. I feel a little scared about if I, just walk down the street, cops might just think I'm doing something bad, and then if I try to explain to them, they won't listen and then just start beating me up and doing terrible things to me. I think there's this anxiety that kind of comes with being biracial, that kind of eats away at you, almost like you have to prove yourself that you're one or the other. For example, I hear the phrase, "You're not Black," all the time. People sometimes think that I'm supposed to talk ghetto or whatever that is. Oh, she's uneducated because she's African American. Because I'm Hispanic or Latino, I can't have a lot of money. Just this weekend, I went with my friend to Urban Outfitters, and we were shopping, and I really wanted to try on this dress. And then this lady that was just there, she was kind of watching me, and I'm just I'm not gonna steal it or anything. I think white privilege is the idea that in your everyday life you're getting treated differently and sometimes with more respect, or people just trust you more, or they have certain expectations of you, you might be smarter or you might be wealthier. Because you're white, it makes me feel guilty sometimes, even though it's not my fault. I feel guilty for having a privilege that I don't deserve. If I was ever the mayor or something that controls the policeman, I would want to go out and look in the neighborhoods where there are people that's very friendly, so you can pick them instead of like these guys that's just doing all this training. It's better to pick people that's more minded with the community than to just pick some new guy and get on the street. Like, it's just not gonna work out. We have like these kids from they're Ecuadorian and they get made fun of because they look Mexican, and they get told on a daily basis, oh, you like tacos? Oh, you like churros? How come I saw your mom on the corner selling ices? Like, it's like, I feel bad for them personally, because I'm like, wow, like, they're not, and like, even though they tell them I'm not Mexican, I'm Ecuadorian, they still get teased.
Okay. I'm going to switch back to my slides, but I just thought that was a good video, again, to hear some firsthand experiences from kids themselves, and also just to serve as a reminder that these are things that kids are dealing with on a, in their day-to-day lives, even if it's not something that comes up when we're seeing them in their appointments. So while we are talking about effects of racial trauma and racism on children, just a little more data. So there have been studies that have shown that children can distinguish the phenotypic differences associated with race in infancy. So as early as 9 months, babies can distinguish their own race or the race of their family from the races of others. And so I bring that up to just point out that I think the idea that children are not born racist and they have to be taught that is true. That's something that has to be learned. But it's not necessarily true that children are all colorblind. And, I think we're past the point now where that's something that we want to teach. And of course we can teach now to celebrate our differences, and, that just makes for a richer environment. However, for children who are continuously exposed to negative images and ideas about their own race, internalized negative stereotypes related to race can unconsciously erode self-perception and capacity. And this may later present in the form of stereotype threat or the fear of confirming negative stereotypes of one's race. And really this can be true for children and for adults as well. There's another study that is pointing out that Black youth in particular are vulnerable to racial trauma as they have yet to develop the skills necessary to adaptively process and cope with racism-related encounters. And again, there's a lot of studies that have been done looking at African Americans, really just because there are such high levels of racial trauma that African Americans are exposed to. But I think developmentally, this is true for any child of color who is facing racial trauma. For adults may be better equipped to recognize racism so as not to internalize it, or they might be able to feel more secure in their differences when comparing themselves to the majority around them. Of course, this may not be true for adults. I think perhaps as a result of racism that they may have experienced over their lives, they may not have developed this protective skills. But kids in particular are especially vulnerable and especially at risk. Okay, so we can zoom out a little more and look at effects on the family. So as I mentioned, for young children who are still in that pre-formal cognitive development reasoning stage, racism has been negatively associated with their self-esteem. For adolescents, experiences of racial discrimination have been related to coping challenges, including higher rates of substance use. And for parents, when we look at parents, those who perceive more discriminatory experiences rate their children as having greater internalizing and externalizing problems. And these parents may also experience impaired psychological functioning and parenting practices, which in turn are associated with greater child emotional problems. So again, we're seeing that this cycle, these cycles that families can get stuck in. So to this point, we've talked about what racial trauma is and its risk factors. We've talked about what it can lead to, but now we can talk about specific presentations. So individuals who are experiencing high levels of unaddressed racial trauma can present with any of the following. So, we have hypervigilance, insomnia, confusion, shame, guilt, depression, anxiety. And you're probably noticing right away that these are symptoms that look very much like those of PTSD. So then the question is, and it's a question that we touched upon earlier a few months ago when Dr. Urban gave her grand rounds, that we have to ask if racial trauma can meet criteria for PTSD. So is criterion A fulfilled? So if we're using DSM-5 criteria, which we do, then racial trauma may or may not meet criterion A. It could, in many cases it can, but if we are not seeing that clear direct or indirect exposure to death, serious injury, or violence, then it wouldn't be able to meet criteria. Of note, if we're looking at ICD-10 criteria, that considers symptoms without explicitly restricting the type of trauma. So if you had an individual who was experiencing all of these symptoms and you could trace it back to racial trauma, then for billing purposes, you could diagnose them with PTSD for whatever that's worth. But in any case, we do have tools we can use to assess for racial trauma and to keep the effects of racism in mind when we're seeing patients. So, first up, we have the cultural formulation interview, or the CFI. And we also learned about this one in an earlier grand rounds with Dr. Liu. So the CFI is useful in conceptualizing a cultural formulation and exploring aspects of a patient's racial cultural identity that are important to them. You may also remember it's very conveniently located at the back of your DSM-5, so it's in the appendix, so you should have easy access. And there are also 12 supplementary modules for different populations, including children and adolescents that are available online, and also a Spanish version online. After that, we have the Yukon Racial Ethnic Stress and Trauma Survey, or the UNRES. And the UNRES is useful to clinicians as an aid for uncovering racial trauma, developing a culturally informed case conceptualization, and including experiences of racism into the diagnosis of PTSD when warranted. So again, talked about there are instances when racial trauma will meet criteria for PTSD, but if the questions aren't asked or the right information isn't elicited, then it won't. So this survey just helps you not to miss those things. And then we have a few other scales, the racial microaggression scale, the perceived discrimination scale, and the everyday discrimination scale. And these are all surveys that have been used in research to measure patients' perception of racism or discrimination. So not necessarily used for formulation, but may be useful since we know that the more exposure to discrimination, the greater the chance of psychiatric symptoms. So these can all be helpful to kind of quantify that. So with that, I'm going to stop sharing my screen and I'm going to turn it over to my discussant. And let me just give a quick introduction. So I have with me today Dr. Dana Collins, PhD. She's a licensed counseling psychologist committed to the empowerment of marginalized youths, adults, family, and communities, promoting social and racial justice, raising awareness about mental health and challenging stigma, and addressing trauma. She currently works as a clinical psychologist with We Care Brooklyn, serves as the president for the New York chapter of the Association of Black Psychologists, and is an adjunct assistant professor at the City University of New York, Medgar Evers College. And I'll also point out, Dr. Collins is also my sister. So I was fortunate to have easy access to someone who is so knowledgeable in this subject and was nice enough to work with me on this and to teach me some really good things. So I thank her for that. And I'm going to turn it over to her. Hi, thank you so much for that wonderful introduction and also for starting us off. You, I think, have set us up really well for the rest of our presentation, Dr. Collins. So I am going to go ahead and share my screen and hopefully it will go smoothly. Okay, there we go. And I also want to thank all of you who are here because, as has been said, it's Inauguration Day and it's been an exciting day. But I want to start us off with a quote that some of you might be familiar with by Angela Davis. "It is not enough to be non-racist. We must be anti-racist." So you might ask, how does this apply here? Well, when we are responding to racial trauma, it's not enough to be neutral. It's not enough to be neutral about the symptoms, about what caused the trauma, and it's not enough to just not be racist. We have to, when addressing racial trauma, directly address and where we can undo harm. So anti-racist healthcare means dissecting the incorporation of race in medical practice, acknowledging and repairing, and taking actions beyond the client level. So we're going to be talking today about different elements of anti-racist healthcare, including some assessment, intervention, treatment considerations, and next steps. So with that in mind, we'll continue defining anti-racist healthcare. So as we've seen, racism can be a traumatic experience. So when we're doing anti-racist healthcare, we also must take a trauma-informed approach. And we see that the CDC, the Center for Disease Control, has put forth some tenets for doing trauma-informed care. And at a basic level, trauma-informed care, the healing focuses on establishing safety, symptom stabilization, reprocessing, and reconnecting clients to themselves and others. And there should also be some attention paid to sociocultural and the sociopolitical context in which the trauma occurred. Now, I do want to say that many of the tenets within trauma-informed therapy or treatment are subsumed within anti-racist healthcare. But it's worth emphasizing the tenets because depending on where you are in treatment, some of the tenets might be especially important to pay attention to. So continuing, going on to assessment, because we do want to start with assessment when treating racial trauma. In addition to assessing symptoms, the concerns, we want to have a good understanding of the client and their cultural background. And we want to really be careful about assuming cultural homogeneity where we think that people within a particular group are similar to each other. We really want to recognize people's nuances and complexities. One of the ways we can do this is by using Hayes' addressing model, which is outlined here. And we can see that it helps to break down different parts of identity that could be important for our clients. And we can also use this to look at how clients' identities intersect. Another thing I want to say about this is having clients talk about their identity can actually be an important part of intervention, because oftentimes what happens with racism is there's a kind of erasure and invisibility. So if clients are able to be seen, if they feel that they are seen for who they are rather than for a stereotype, that can be really empowering. So we will continue with assessment. And I want to note that, of course, Dr. Collins talked about other forms of assessment. Those were more sort of structured, and these are more sort of open-ended approaches you can take. So we want to assess how microaggressions, discrimination, different forms of racism are showing up in our clients' lives and how they are impacting them. And we also want to, as much as we can, touch on some of the other things that Dr. Collins talked about, intergenerational and historical trauma. So asking some questions about that. Of course, we don't only want to talk about the negative. We don't only want to focus on sort of the the deficits. We want to assess for individual and collective strengths. This is really important, not only because we can keep these things in mind when treatment planning, but also because it can help the client feel a sense of hope. And again, that sense of empowerment that is really important with trauma. I do want to note that safety is the trauma-informed tenet of safety is really important here, because we don't want to trigger our clients. We don't want re-experiencing to happen. So we want to talk with them about what can we do, what can I do as a clinician, or what can we do together to make this feel a little less upsetting. So collaboration is really important here. So going forward to an awareness of racial issues. So this is a very broad thing, awareness of racial issues. So I'm just gonna touch on 3 things here. So self-examination and self-awareness are really important. Before helping others, we really need to have a good idea of who we are in terms of our identity and also culturally. And we also need to understand Sorry about that. Am I back? You're back. Okay, I'm gonna share my screen again. Okay, I was in the middle of talking about differences. Clients might have concerns or worries about working with a clinician, especially if the clinician is culturally different. So we want to talk about and ask them, how does it feel to be working with somebody who's maybe different from you? So do talk about those things. The third point is about psychopharmacology. And I want to say that I am a psychologist, so I can't give specific recommendations for psychopharmacological treatment, but I just want to touch on something that people in terms of what is prescribed, and to continually make efforts to strive for cultural competence. Okay. So some treatment considerations, some things to keep in mind. So we actually do want to talk about race and racism and discrimination, and we want to do it early. As we've seen, these things do impact our clients, and clients might not realize that treatment is an appropriate place to talk about these things. They might have some misgivings. So we have to assure them that this is the place for it and that we are equipped to do it. So it is up to us as clinicians to bring this up if the clients don't. We really need to take the lead on this. So the next point is psychoeducation. Psychoeducation is really important throughout this process. Knowledge is very important, and knowledge can be empowering for clients. But help clients to get education on how racism and discrimination can impact concerns and symptoms. Now, as Dr. Collins said, clients may not always be aware that they are experiencing racism, so they definitely may not realize that they are realize how it is impacting them. But it's important for them to know, because it's important for them to know more about their concerns, but also this can help them to do some externalizing. So rather than blaming themselves for being angry or depressed or anxious, they can connect it to these negative experiences they're having. Validation. So this is a really important one because racism at its core is there's a lot of invalidation and a lot of silencing, and we really want clients to feel heard, we want them to feel understood, and we want them to feel that this is the place for them to share and be seen. So assess and address internalized racism. So Dr. Collins talked on this a little bit, internalized racism. Unfortunately, when racism is really pervasive, it becomes really difficult to resist taking in and accepting those messages. So as much as we can, we want to see how much clients have sort of brought into these stereotypes about themselves and their groups and try to undo and challenge. And of course, we can't be perfect at this. We can't be perfectly culturally competent. And it is okay, and it's a good idea to let clients is, see, maybe, am I frozen now? No, you're unfrozen now, but it keeps going out. Okay, I'm sorry. Let me know and I'll see what I can do. So racial socialization is basically messages about race and racism within families. And it has been shown to be helpful in mitigating the negative impact of racism and discrimination within youth. And there are, in the literature, there's 4 different types that are usually looked at. And I'm gonna really focus on the first 2, cultural socialization and preparation for bias. So cultural socialization is anything that promotes cultural or racial pride, and it can be implicit or explicit. So it could be just simple verbal messages uplifting the cultural group, or it can be, like we saw in the video, one of the children talked about, oh, we eat Venezuelan food. That's an example of cultural socialization as well. That is perhaps the most widely researched form of racial socialization. And it's been shown to not only mitigate the negative effects of racism, but also to be associated with a lot of positive things like higher self-esteem, better coping strategies. Preparation for bias is also very widely researched. And the results of it, or the outcomes, sort of depend on what is included in it. If it only includes messages that, oh, there's racism, you're going to experience racism, that has been linked to youths experiencing anxiety and fear, because it doesn't really tell them what to do about it. But if the warnings are paired with some actual preparation, some strategizing for responding, that strategy is more, preparation for bias has been shown to increase coping strategies and some other positive outcomes. Now, promotion of mistrust and egalitarianism have been shown to be a little less helpful. So I'm not going to spend very much time on that. But these are good things for us as clinicians to be aware of. We can be talking to caretakers about them and encouraging caretakers to engage in them. Okay, so I now want to continue with interventions by presenting a couple of models that can be used. The first is the HEART, Healing Ethno and Racial Trauma model. And this was specifically developed for Latinx individuals, families, and communities, but there are many components of it that can be adapted to other groups. So it briefly, and you can learn more about both of these models in the references and also the resource list we put together. It addresses the internal, so the symptoms of trauma, and then also the external, so these systems that are responsible for the racism in the first place. And then there is the embrace model, the engaging, managing, bonding model. And this is specifically for African American youths and their families. And it is a 5-session racial socialization intervention. And the goal is to equip families with tools to have conversations about race and to foster familial bonding. Okay. So in the case that those models are not available to you or you don't have adequate training, these are some things that can be done more immediately. So cognitive restructuring, we can do some adapting here. So typically with our clients, we like to do disputing questions. But with somebody who is experiencing racial trauma, this might not be indicated. So it would probably be inappropriate to say to a Black client, well, what evidence do you have that people think that you are not intelligent because you're Black? That would probably be really invalidating. So instead, we can internalize the restructuring or the disputing and ask them, well, what evidence do you have that you are unintelligent to your Black? So because you're Black, so bring it back to the client. Second point, connecting aspects of psychoeducation directly to the client's lived experience. So I talked a little bit about psychoeducation, but it warrants re-emphasizing. It's really important to directly point out to clients, help them to understand where racism is occurring in their lives and how it is impacting them and how it's presenting in their concerns. And then adapting exposure. This is especially done, as we know, within CBT, where we arrange for clients to be in a setting where they face something that makes them very anxious, but is really not all that dangerous. So with racial trauma, we don't want to tell clients to go into a situation where they will experience racial trauma. That would be not indicated. But what we can do is help them to identify situations in their life where they might already be experiencing racism anyway, and then helping them to respond, strategize. So the next, I'm going to move on to sort of the final portion, which is systemic intervention, because again, it is really important to do the individual clinical work, but we also have to challenge the systems that are responsible for racism in the first place. So the first recommendation is developing longitudinal pipelines nationwide. So this is about diversifying the field, attracting more diverse clinicians and making training more accessible, making our programs more accessible. The second point is implementing culturally aware mentorship training. So this is a little bit of a newer idea. There's not a whole lot of research on it, but the National Mentoring Research Network has a model for this. And what happens is that clinicians are paired with mentors, and they can talk about issues related to race and culture and areas where they need additional training. And again, these programs are still being researched, but they are worth exploring because they're relatively easy to put together, don't require a whole lot of investment. The next point is mandating anti-racism training. So in the past few years, implicit bias training has become really popular. And while helpful, there is some research showing that it may not be enough. So anti-racism training goes beyond implicit bias, and it looks more at not only the ideas that individual people have, but also the ideas that are ingrained within institutions, the approaches or ideals or values that are ingrained within institutions that might actually be racist.
And finally, the American Psychiatric Association recently formed a presidential task force to address structural racism throughout psychiatry. So there is a website, and on there you can find a reading list. They have webinars and trainings, and they also have some recommendations for how clinicians, psychiatrists can get involved. And with that, I will turn it back over to you, Dr. Collins. Thank you so much, everyone.
Thanks, Dr. Collins. And really now we have time for questions. So if anybody has any questions, we can take those now.
Thank you so much, Dr. Collins and Dr. Collins. I really appreciated how you had the multidisciplinary psychiatry and psychology approach, and also how you gave us some real tangible suggestions for measures and frameworks and interventions and continued training opportunities that we can all take. As Dr. Stacie Collins mentioned, if anyone has questions, please feel free to put them in the chat or raise your hand, and we'd be happy to work through those.
Oh, there's a question about the final point, sure.
That was, I think, on the slide when you cut out, which now I don't remember which slide it was.
Oh, I'm so sorry about that. I think I remember, let's see. I do remember where that was, though. Let's see. Can everyone see my screen?
Yeah.
Okay, so I'm just gonna make this, I have to move everyone. Okay, here we go. Was this it? Not sure if the person is still here, but this was the slide. This is one of the slides where I cut out anyway.
I think it was the next one.
Oh, the next slide. Oh, I see. This one?
I believe, yes.
Okay.
We're saying yes.
Oh, okay. Yes, okay.
Do you want to maybe?
Oh, I'm sorry. Should I go over? I can go over it again. So, do you remember where I cut out? Should I just?
No, just the last point. The one about being collaborative, I think.
Okay, I'm sorry. I wasn't adequately reading. Oh, yeah. So this is a really important point, both from the standpoint of anti-racist healthcare and also from trauma-informed care, because there is, in general trauma and with racial trauma, there's often a loss of control and a loss of agency. People don't have a choice. Power is taken away from them. So by being collaborative, we can restore some of that. And there are a lot of ways to do that. One thing that I like to do regularly in treatment is to ask clients, how is this going for you? What are some things that I could be doing differently? What are some things that we can be doing differently? I also like to talk to them, and I think most people probably do this, about different treatment options to see what their thoughts are. So really sort of co-constructing treatment.
Great, thanks.
Thank you. I see a number of requests for slides and references. We've talked about this as a committee, and we want to make sure that we're reflecting that this is y'all's work. You put a lot into this. And so to not put you on the spot, we want to remind people that this talk is being recorded and it will be up on our website. And if speakers in this series are comfortable sharing their slides and references, we will distribute those as comfortable. But we want to be mindful of not putting folks on the spot, given how much work goes into these presentations.
We are happy to share the slides.
You are? Okay, great. So we will get those to you all.
Yes, thank you. Yeah, we're really hoping that people want to learn more about this, so we're happy to share.
Great. So we will share the slides and the resources with the recording on the website. Thank you.
Great.
Any other questions for today? So these will be, Sam, could you direct us to where these are on the website, these talks? Thank you.
Thank you all.
Well, this was a wonderful presentation, and as you all acknowledged, a really exciting day. So we actually have a great turnout, which I think speaks highly to how valuable we find this topic. And I'm so happy that we were all able to come together on such an exciting day.
Yeah, I really appreciate the turnout and the engagement. Thank you. Thank you so much, everyone. It's been great to be together today.
Thank you.
Thank you.
Thank you. Bye.
Just wanted to say thanks again, Dr. Collins, and thanks again to your sister, also Dr. Collins, for joining us today. And I'll make the slides a PDF if that's all right, and I'll post them up on the department website that I listed, along with your recording. Okay.
Okay, sounds good. Thanks so much.
Thanks again, everybody. Have a great rest of your Wednesdays. I'll see everybody not next week and not the following, but February 10th. Thanks.
Thanks.